we need to have an honest conversation about the frontier of AI in healthcare. If you're a bedside clinician, if you're someone who's interested in going into healthcare, then this talk should be something that you might be interested in, especially if you have an aptitude for technology and its use in transforming what I see the future of healthcare and how we deliver care to our patients. So first, just a little bit about me. I'm Shane. I'm a nurse. I've been a nurse for over just about 15 years. Most of the time in my nursing career I spent in the ICUs. I spent 7 years in neuro ICU, and the remaining portion in the medical ICU. And I did a stint in clinical regulations, all for a large hospital organization, level 1 trauma center, the sickest of the sick patients. Really learned a lot from my time there. And now, more recently, I'm interested in kind of leveraging that experience into how we can shape and transform what it is that clinicians do, and how AI plays a large role in that. So first and foremost, what is AI, and how do we see it being integrated into healthcare? So everyone is familiar with ChatGPT, released in 2022. So at that time, I really started to kind of play around with what AI was. And of course, it's just, at that point, just a chat model. Hey, how do I tie my shoes? You put an answer in, and then magically, the large language model decides that if I say these string of words, hey, how do I tie my shoes? The math in the background will try to come up with a logical output in exactly how to give advice to the person. And so, of course, this is current state-of-the-art model in Grok. And it says, hey, Shane, pretty sure you meant tie my shoes, right? Classic typo, which is interesting because how do I tie my shoes? I didn't typo there. It was at this time where I would start to ask questions like, what does fluid status have to do with end organ ischemia, right? And so then we start to go into these kind of clinical questions about probing the models. What do they know about taking care of patients? And how can the models be effective at either guiding our clinical decision making, or at least being, like a clinical decision support, right? And so we know that the current state of the models is that they're very hyper aware. They have access to very large, broad databases, and they're very good at pulling in multiple source data. So at this point, I knew that AI was going to completely transform our medical system. For the longest time, our education has fought and fought and fought to train us like robots. How can we ingest all of the information that they tell us is important so that we can act as a database to be reactive to a situation that we see clinically, and then also query that against all of the patient set that we've seen in our practice, which is why we call it a practice. And then we leverage those two querying methods to ultimately make a decision that affects the clinical care that we provide. Now, the poor residents in the current system, they have to act like that all the time because they don't have the clinical nuance or the practice to fall back on to kind of make the human connection within that. And so, in effect, not to really the fault of their own, but they end up acting like robots. And so the LLMs are going to be much better at that. And so at that point didn't really, wasn't really interested in pushing the actual broad scale application of what an LLM can do to the clinical decision-making model that is medicine right now. As a nurse, what I wanted to leverage was how can the LLM perform the jobs that I don't want to do? And not because I don't want to do them because they're difficult, but because they're monotonous or time-consuming, or ultimately they didn't add to the value of the care that I was giving. So I started playing around with that, and I said, man, I'd like to make an AI agent nurse. Agent is a hot topic word that we should be aware of. Right? So all that an agent is an isolated instance with an LLM serving inference to the agent so that the agent can execute on tasks. Now, that's obviously a large umbrella. These tasks could be, giving a paper output, or giving a synthesis on a broad data. My idea was that this execution could be a write function into the EHR. Now, at the time in 2023, kind of late going into 2024, the models really weren't quite there yet. You could put in kind of these broad queries, and if you asked it about kind of these clinical decisions that it could query the large databases, more often than not, it would put out pretty reasonable results. But in order to actually build the system that would have the agent function as an agent, like a clinical documentation robot, the models weren't there. So I kind of had to back off a little bit on that and kind of wait for the models to catch up. The next innovation was Claude Code. So when Claude Code came out, it really unlocked a lot of that engineering potential. It made it so that natural language could be fed into the model, and the model would be good at coding, something that I'm not good at doing, but have interest in. And not only that, but this coding agent would use your local file system to save the artifacts. So if we go to the terminal here, we can just type in Claude. All right, and I ask Claude, I say, build me an agentic nursing harness. Make no mistakes. And of course, after it's done discombobulating, then I'll have exactly what I want, right? No, of course not. That's not how it works. But the possibility is there. And what's happening is there used to be two subsets of people that were making the decisions about how the clinicians accessed and cared for the patient. The development cycle and the institutions. Now, the institutions had to answer to the regulatory bodies, and the devs had to answer to engineering principles. Right, and so if the clinician said, hey, you know what, I really wish that our charting system didn't have to do X or Y. I think that we should do Y before X. And then that would be brought up to, obviously, the hierarchs. They would deliberate on it. They even might make a reasonable query to the devs and say, we need that to happen, right? But the dev only knows the engineering principles behind it. And so the reason in all of this loop here of exactly why the clinician wants Y before X is lost. And ultimately what I was noticing was because that provided better care to the patient. Right, and so all of this mess can be disregarded if we can learn how to structure our specification precision and decompose our workflows specification precision, and decompose our workflows. Right, because this is difficult for everybody, but it's that initial query of like when I'm talking to the bedside clinical manager of like, well, I don't like that I have to go to this other screen to see the resource needed so that I can chart the numbers on this screen over here, and there shouldn't be an extra step in there, right? So now we have the clinician who has these issues, and we can bring them straight to the dev, which is a coding agent. Right? And as long as we're very precise about what it is that we want, and we can decompose our workflow into small enough bytes for the dev to understand, then he can make decisions in the code base right away. Ultimately, what this means is that the clinician can decide tooling. And just like you wouldn't go on a construction site and tell a worker that he needs to use this hammer, or he needs to use his tools in a certain way, right? We can kind of guide him in saying that for this job set, we usually use tools 1, 2, and 3. Now, how they get to those tools is up to the clinician. And there will always be an outcome metric that is dictated by clinical practice guidelines. These clinical practice guidelines are necessary regulation to tell us that every patient in this scenario needs to follow this type of procedure. Now, these outcome metrics are exactly what feeds back up to this jumbled mess up here, because the clinical practice managers need to have those clinical practice guidelines at the forefront of everything they do. And as long as they keep this regulation body happy, right, then they can be assured with a stamp of approval that the best care is getting down to the patient. Now, this might be true 80% of the time, a large percent of the time, but it's the 20% of the instances that what it is that we're saying we're doing to help the patients doesn't do that. Okay, and what happens when what we say we do isn't actually what's happening in practice? Burnout. Because the clinician is the person that delivers the care. The clinician is bedside facing, and he has direct hands on exactly what's happening. So after kind of stepping back from that long tangent tirade, how does this relate to large language models and AI in healthcare? I'm not particularly excited about the conversations that are currently being had. Right? These are conversations that I think we've all known for a long time. If you open up a chat instance and you just search for clinical knowledge, the models are already there. Right? So it's not about a matter of intelligence. It's about context. How can we give the models the right contextual information at the right time to make the best decision for that patient? Now, of course, OpenAI, Anthropic, xAI, they're all going to take a stab at this, right? But who knows better than the bedside clinicians exactly what is contextually important, right? And so then they fill their teams with who? And I'm not knocking them. They're just making informed decisions for their business, but largely physicians, right? And we do want the brightest of minds to be involved in the next generation of AI in healthcare. But very logically, the term bedside manner, right, is not a metric of, oh, that person was rude or insensitive. In my experience, that is a metric of being contextually aware. Can the physician put his pride of his practice underneath the care of the patient to understand them? When that happens, it doesn't matter how rude or abrasive the physician is. If they're giving contextually relevant information to that patient, more often than not, it's received. Right now, it doesn't necessarily change behavior to better their outcome, but this is crucially important. So as we think about this, how is it that we, as bedside clinicians, can provide the best context to the AI models to improve our care that we can give, right? Not to do our job for us, but to enable us. All this talk is about having clinical decision support. It's a big hot topic term. All these epidemiology studies and gene therapy and medicine and you name it, all these very high arching goals, right, which are very glamorous, and I think that there's definitely a large role to play. But what's underneath all of that is the actual tooling that would free up the minds of the bedside staff to do their job effectively. I want to continue exploring this, and I think part of this would be to kind of broadening these concepts that have been at the frontier of AI, and trickling them down to the people who might not be as, let's say, autistically involved. Because the more people that we can have that are able to describe their natural language processes to the models, then the more that will surface of what it is that we can have these models do for us. So now that I've continued developing an agent, these are the foundations that I've landed on. And a lot of this has come from coding models. And I think that there's a lot of stark warnings that we can get from the directions that the institutions are going inside of the coding models. And we need to make the decisions now as the healthcare sector as to what could be possible and how do we make that happen. Right, and so I mentioned Claude Code, by far the superior model. It's, let's say, state of the art. Now Claude Code offers this terminal interface here, right, and that terminal interface gives access to my local file system. Now, all that does is that it injects the LLM into a harness. That harness is operating within my local system to read and write. Read and write. Okay. It can also search, and it gets more complex than that, but really that's the fundamental basics of it. It can read your files, and then it can write more files. Okay? Now, the black box warning is, what does it do in the meantime in the harness? Right? And Claude Code has decided that, well, in order for it to be agentic, we need to give it a bunch of instructions. Right? And these instructions might be, make sure you don't delete files, make sure that you, stop warnings, and all of this kind of guidance, which is important. But this actually ends up being the context of the model. Right? And so the context of the model might be that I'm operating in a specific directory. And that directory has an architecture file. and a README. It's got all these things that I can learn about the file system. Right? And so your local file system becomes the database for which it can query. Now, hopefully the end result of gathering all that context is that no slop, right? We don't want the coding model to output something that's sloppy, something that doesn't make sense, something that's not coherent. And then downstream from that is we need it to work, right? The program needs to function. Within this entire system of how a coding harness works, who gets to decide what this harness does, who owns the information, and how are they going to steer it, right? Anthropic is going to steer that. And then what happens when Anthropic says, oh, we can't offer this model, and we need to limit it, right? Or it's too dangerous, and so therefore we're going to just get rid of it, right? These decisions are not user-based decisions, these are corporate decisions, and many of them could be made for exactly the right reason. But I want to just kind of continue this mind exercise here of how does coding relate to healthcare? So we're always going to have the state-of-the-art models, right? Let's pretend that this is OpenAI, and they have their healthcare initiatives, right? And so OpenAI is going to create a harness. And that harness is going to operate inside of the medical system. Right? And that medical system has an EHR, policies. It's also going to give it access to resources. How about the monitor? Okay, what does this become? Context. Now, the question is, who decides what context the LLM gets inside the medical system? Right? Is it the medical system? Is it a collection of physicians? Right? Or is it OpenAI? Because they're the ones that are serving the inference from the LLM. And so it's their technology that is ultimately delivering care. I don't know the answer to this necessarily, but I do know that when people get involved, bureaucracy comes into play, and when bureaucracy comes into play, the speed and efficiency ends up hampering the delivery of care. And so the current state of healthcare and AI is that this is going to happen, and not only is it going to happen, it's going to happen exponentially. We're here. And notice, when we're thinking about this, OpenAI is not in the fault. Anthropic is not in the fault. The medical systems aren't even in the fault, right? What could truly happen is that we have amazing advancements in medical AI, and almost none of that will impact the bedside clinician. And I don't mean impact like it'll change the entire scope of what we're doing, but it won't be made useful. You know, a lot of these decisions are like, oh, can the LLM diagnose, right? Can the LLM, guide care? These are not useful questions for me. These are not useful, right? It's can the LLM chart 300 milliliters of urine at 1700 for bed 17. Okay, this would be a voice command, right? Then the agent would get that command. It would query an MCP server. That MCP server has access to the EHR. And then it would write 300 milliliters at 1700. That's useful. That's not only useful for me right now, that's useful for every nurse at the bedside every hour. And the only amount of thinking that has to happen is within this harness, right, is another LLM that's a router. The reasoning is not, oh, can we diagnose this patient with cancer? The reasoning is the user has a voice prompt that wants another agent to find bed 17, find 1700, and chart 300 milliliters. Right, 3 numbers. Gets passed to the agent, gets passed to the server, gets written in the EHR. This is doable. This is very doable. And it's doable as long as we have enough nurses who can describe exactly this process, right? Look at bed 38's vitals, chart if normal. Otherwise, let me or neighbor know. Okay, so I'm busy let's say I'm busy in room 36. And I tell the agent, hey, do you mind just checking? Can you check on 38's vitals? And then if they're normal, chart them. Okay, but otherwise, let me or my neighbor know. This is very doable, very easy. We have to be able to start speaking up and let other people know that this mode is gone. That this opportunity is here for us if we can get enough people on board to be able to communicate with the agents, to be able to make the changes to our clinical systems. Because I'll tell you what, like, I have a lot of respect for Epic and what they put out. I've had great experience working in Epic systems. Their models, whatever their agents are, I don't think they're going to be helpful. You don't want to know why? Because we have best practice advisories, right? Sepsis alerts. Very rarely for me at the bedside was this helpful. Very, very, very rarely. Right? It was helpful for the people at the top. Right? It's not helpful for the people at the bottom. And so, Epic, God bless them. I hope that they put out good systems. But my faith is very little that they're going to do that. Right? It needs to come from the bottom up. It needs to come from people who have experience and actual problems with their daily work. And anyway, so I hope to keep this lecture series going. Yeah, but I'll stop for there.